and welcome to this special edition of the Rural Doctors Programme. I'm Jerry Gannon. Thanks for joining us. Over the last few years, we've had a number of opportunities to interview Professor John Murtagh about his approach to general practice. And some of these interviews have never been broadcast in their entirety. So we thought it would be worthwhile to put together a couple of these interviews that between them give an excellent overview of the role of the GP, as well as some advice about approaching specific problems. First up is an interview recorded in Fremantle in 2008 where Professor Murtagh discusses pain management.
John, welcome to the program.
Thank you.
Could you talk about some common conditions that might present with very atypical features? I was thinking particularly of the recent case where a poor GP registrar missed a case of Addison's disease, which surely is as rare as rocking horse manure.
Yes, well, I've heard about this, and it's something that always worries us. I think any of the diseases, the endocrine diseases, from thyroid through to Addison's disease to Cushing's disease, all these conditions can be atypical and very difficult to pick. There's also what I call the masquerades, which goes with the diagnostic model that I have, and this includes depression and diabetes and drug side effects. All these things can be very tricky. They're what I call the problems that present with undifferentiated illness or vague problems. So you have to have a strategy for them. But the endocrine problems, such as Addison's disease and hyperparathyroidism, for example, are very, very difficult. So you just have to have a high index of suspicion. Diseases like systemic lupus erythematosus, the connective tissue disorders and the vasculitides, they are very difficult too.
So how do you tread that line between over-investigating and missing a very important diagnosis?
It is a very difficult question, but I think that if you have a good diagnostic model, if your guidelines to working out a problem are good, such as tiredness or abdominal pain or headache, your provisional diagnosis should be fairly close to the mark. And if you're fairly good at coming to a reasonable provisional diagnosis, you can be fairly specific with your investigations. But I think it's important that you do have a strategy for investigations, and I have a first-line list of investigations, which I do on these patients, and it's very simply, I think we all have them. It's a full blood examination, ESR, CRP, always look at the urine and do urea and electrolytes as a first line. And sometimes that gives you a clue to the diagnosis, but I think the point you're getting at is the worry about over-investigation, which I think we do, and I think we have to try and be a bit more specific.
So back to the history and having a system.
Yeah, the history is so important. And, you know, the old model, patient comes in, you see them, you can make a spot diagnosis, you can make a provisional diagnosis, and then, of course, the history, and you must examine them. I always remember my mentor said, whatever you do, always examine your patient. And a lot of the mistakes I see are made by people not properly examining the patient.
How do you deal with patients who become a bit too familiar?
I haven't found an answer to that, except I don't make a fuss of them. I don't, all that business of being really nice to them and being very friendly, that goes out the window with these patients who are a bit like that. I'm just very courteous to them. I don't spend a lot of time with them. I just make it a very matter-of-fact basic consultation and try and cut it fairly short. So I don't spend a lot of time, and you have to be fairly careful that they don't become too dependent on you.
Yeah.
I don't invite them to ring me back. I do invite patients to ring me back for results or if they've got a problem they're concerned about, but patients are a bit like that. I just keep a little bit of a distance, keep the relationship very professional, if I can put it that way.
And what about those patients that just keep coming back but never ever seem to take your advice? Which I guess is the diabetics on the diet of Tim Tams, whiskey and cigarettes.
Yeah, well, I think you have to confront them. I think it's up to us really in as nice and as diplomatic a way as we can to confront these people and say, look, I'm here to help you. I can meet you halfway, but you have to help yourself. Yeah. And unfortunately, we're not winning. Now, we've got to look at why we're not winning with you. Why are you still smoking? Why are you still having too much alcohol? Why you are still overweight? Why you're not doing your exercises? And then I presented to them, look, it's in their interest. And I just try and coerce them with this confrontation to follow the line, that it's their health. It's not my responsibility, it's their responsibility.
To try and get them to own it.
That's right.
John, one of the things that GPs see a lot of is patients with chronic back pains, often many years standing. Could you give us some ways of approaching them, and especially when they're on a load of medications?
This is a very big problem. It's something very dear to me, having spent a long time in rural practice where these problems are rife. The chronic back pain problem, you know, the people who are on all these nasty opioid drugs, you know, the Panadine Forte, all these drugs which really just seem to go on and on. I think what one has to do is to try and wean them off the drugs if you can. It is not easy, but there are various strategies you can use, and there are some that have been used successfully by some people for a while. The only things which are proven on evidence-based medicine to help backs is mild analgesics, such as paracetamol, keeping active, doing exercise, and also what they call the heat packs. Heat packs have been shown, in fact they call them heat wrap, and a heat wrap is where patients are able to put this object around them, which maintains a lot of heat around the low back. So those things have been shown to help them. So I think we've got to try and get back to these more basic, simple things. So what I try and do is get the patient off the opioids and the nasty drugs and give them the reason why. You've got to sit down and explain why you do this. So you say you just want to get them onto paracetamol. You get them to keep active. You get them to do exercise. Now, if you're lucky enough to have a allied health professional, such as a really good physiotherapist, who can teach them exercises, who can give them mobilisation or physical therapy, or teach them Pilates or Feldenkrais, just to get their mind off their pain and to be focusing on improving their posture and getting their back supple, that is a very good strategy. What I try and do is what is a trick which was devised by a very famous New Zealand GP, and that is, I say to them, look, we want to get you off this medication, and you make a pact with them in this, that they want to get off it too. So you try and just keep them on paracetamol, and then I usually put them on amitriptyline, good old triptanol, particularly at night. You start off with, say, 25, 50 milligrams at night, and you say you're putting them on a drug which you tell them it's an antidepressant, it's to help the nervous system, and you point out to them that it can help people with sciatica, and you then gradually bring in amitriptyline and you try and phase off the opioids. And quite often you get excellent results. And one of the reasons why we have found we get excellent results is because a lot of these people with chronic pain are depressed. So you're treating their depression, and the amitriptyline, as you know, helps it's neuropathic, so it helps any referred pain or sciatic pain. So that's what I try and do. I try and bring them in with amitriptyline and wean off the opioids and hope that it works. Another thing you can do, which has been shown to be effective, is if the person has evidence of inflammatory pain, in other words, the pain is worse at night, I think it's worthwhile putting them on a solid course for 3 or 4 weeks of a non-steroidal anti-inflammatory, and I like to use one of the newer ones, and then see how you go with that. Because sometimes when they take it religiously for 3 or 4 weeks and the inflammation settles down, you can then just rely on paracetamol better.
If you're trying to wean these sorts of patients off opioids, and I'm thinking particularly the ones that are on MS-Contin or slow-release tramadol rather than loaded Panadine Forte, what sort of timescale are you looking at? Do you wean them over a month or 6 months or a year?
6 to 12 months is that. Sometimes you may never wean them off it, but that's what I try and do. First of all, my first objective is to get to 6 months, and then I might, if I feel we're sort of winning, I'll extend it to 12 months. But that's the sort of time frame you're working on.
And the psychological and the physical are so intertwined here. Do you think that the pain causes the depression, or that the opiates cause the depression, or does the depression cause the pain?
Very good question. I think both, but I think chronic pain, that is pain longer than 3 months, will certainly cause depression, and then you get a vicious circle. You know, the depression will exacerbate the pain, it will magnify it. So I think that's, you don't have to go with amitriptyline, you can probably use some other agent, but the experts who have been doing this work tend to favour amitriptyline.
And are you looking at amitriptyline in an antidepressant dose, or just in a kind of a sedating dose
No,
at
more
night?
of a sedating dose for a start, and eventually you may move up to an antidepressant dose. The research that's been done on this has shown that up to 50 milligrams can be effective. And 50 milligrams is not really an antidepressant dose. It's much higher.
Would you sneak an SSRI in there, do you think, as well?
You could do that, you could add that, but I think the evidence is that the amitriptyline is better than the SSRIs for this. And you may have read recent literature or press about the fact that it's been shown that psychotherapy is much better than SSRIs. So that's very interesting. By the way, the NSAID that we like to use is Mobic. We find that's a little bit safe, and they seem to get better results with this. So there's the non-steroidal anti-inflammatory is also worth a trial, but you have to know your patient and work out who's got inflammatory back pain, or who's got what you might think psychogenic back pain.
Do you have any solutions for what I call computer neck? You know, those stiff, very sore muscles from people who are sitting at a desk all day operating a mouse and a keyboard?
Yes, as a sufferer of this, I do have some ideas. I think it's important that they get their posture right, that they have an elevated platform or have their computer elevated so they're looking more or less straight ahead and not having to bend their neck a lot. But they should get used to doing regular exercises like the rotation exercises. So they must take time out. It's like the person with back pain having to stop, they're going on a car trip, having to stop every half hour. People on the computer should take time off regularly, maybe every 10 to 15 minutes, and do their exercises. Really get the neck stretch, get in the habit of doing the bird exercise like that, get in the habit of doing the rotation exercise, drawing circles in the air, for example.
Learning to touch type, I think, always helps, so that you're not always looking down at the keyboard.
Yes, well, I can't touch type, so that's a problem. The other thing that we talked about before, the evidence is that hot packs are good. So if you can get a hot pack, you know, get some a wheat pack, put it in the microwave. The heat wrap does certainly help.
And many of our patients also complain that they've been to the physio and done the exercises and it hasn't worked. My experience often is that they've given up a bit soon, but how long would you persist?
Well, I think they should be doing exercises for the rest of their life, really, even though they may not be getting good results from them. But the exercise, people won't always respond to exercises. This is why I think you need other strategies like using heat and having breaks from their work. I think that the exercises are important, and I think one of the best exercises is swimming. So if you can get people to swim, particularly in a warm pool, that certainly will help a lot of problems, because a lot of them get muscle spasm, and you can actually feel the muscle spasm in a lot of these people, particularly around the neck. And I am not sure about the effectiveness of acupuncture, but I do know that some people who are skilled at acupuncture get very good results with treating these necks and backs. And I think if people have a trial of acupuncture and respond, I think that's a good way to go.
It sounds like a lot of West Australian shires might be applying for hydrotherapy pool grants.
It's not a total solution, but it might be part of the solution.
Yeah.
Because everyone responds differently. Of course, the big thing about it is prevention. Very important, the way we lift, and it's very important to have a good bed with a firm mattress, and most importantly, it's important to keep to ideal weight, because probably most of the patients I see with low back pain are overweight. So these are the preventive measures which I think are really very important. But it's a universal problem, it's a difficult one to tackle, and I do think anyone who's got back pain, has had back pain for a few weeks that's not responding, it's very important that they see a therapist who can give them effective spinal mobilisation and manipulation, because that has been shown to help people recover quickly from back pain. So it's worth a trial. So I think it's important for GPs, if they can't do it themselves, to have a good physiotherapist or osteopath or chiropractor who can provide that treatment.
And finally, John, do you have any advice for the doctors who are studying for the FRAC GP, apart from buying your textbook?
Apart from buying a textbook? Yes, I do. I think they have to try and get past exam questions, and they have to get if they can, I know it might be a bit difficult for country people, but get in a little group and study together and help each other. I know the people in the city do this, and that's a really good strategy. They have to get hold of past papers and questions and work their way through them. Go back through past issues of Australian Family Physician and look at the questions and the main topics. Get themselves a good medical atlas and look at good photographs of common problems. There's a very good book by Susan Wern on how to sit for the examination. But what I would really advise them to do, and this is what I advise my students to do, as well as my registrars and doctors sitting the exam, is to learn the dirty dozen. I don't know whether people refer to the dirty dozen, but these are the dirty dozen topics, but I call them the essential dozen topics. And these are the topics that the various health centres around the world have recommended. And I've got a list of them here. I knew you were going to ask me this question, Olga. It's diabetes, particularly type 1 diabetes, chronic kidney failure, which tends to go with the diabetes. So if they know everything about those topics, they know a lot about medicine and they'll do very well in the exams. There's coronary heart disease, there's chronic heart failure, hypertension, which is often related to those, stroke, they must know about stroke, but they're all related, of course, to the coronary business, and so they have to know about hypertension, hypercholesterolemia. There's thyroid disease, particularly hypothyroidism. There's asthma and chronic obstructive pulmonary disease, epilepsy, the sick febrile child, and chronic mental illness such as depression and bipolar disorder. If people know all those topics well, if they get Murtagh's General Practice or any good textbook and they know these 12 topics really well, they will pass the exam, providing they keep their cool.
On that optimistic note, John, we'll finish. Thank you for joining us today.
That's a pleasure.
Our next interview with Professor Murtagh was recorded in 2009 and has never been broadcast. In it, he discusses all aspects of general practice.
John, welcome to the program.
Thank you.
John, could you give us some ideas as to how you begin a regular consultation with a new patient?
Yes, I think it's very important to have a structure to it. The first thing I'd like to say is it's so important to develop an empathy with any patient, particularly a new patient, and just be very friendly and warm in the way you approach them. Shake their hands if possible. Always ask them what name they like to be called by.
Yeah.
I think that's very important, and take note of that and try and remember that. I then ask them to spend about 30 seconds or even a bit longer to give a picture of themselves. I ask them, say, will you please give me an idea of who you are, where you come from, and just a bit about yourself, including the important things in your life. And that's a starting point. I might add, if for a new patient, I like them to fill in a form, a one-pager, which has information on it. And so when they come to the practice, and quite apart from filling in their personal particulars for the practice records, they have a one sheet to fill in about themselves, about their medical record, about what operations they've had and what significant problems they've had, what medication they're on. So I have that sitting in front of me. So it's very important to be orderly.
And do you get a chance to read that before they come into the room, or is that just something that you scan while they're
I
there?
scan while they're there, and I might highlight some things. I see you have a problem with your thyroid, or you've had a problem with the diabetes, and so on.
Yeah.
So that gives me a very quick pen picture. It saves a lot of time.
Yep.
And then I ask them set questions. Why are they here? I think that's very important to say now. Why have you come? I never ask them, what can I do to help you? I ask them, why are you here and what is the main reason you're here? Just so that I get that. And then we analyse that, analyse any presenting problems. So I then take a quick history which involves the presenting problem, a quick symptom review, always ask them about their past history, very quick family history. You've got to slip through this in a logical manner.
Yeah.
And the drug history is very, very important, of course. But then I have 6 questions. I ask all of them to make sure they're not missing anything seriously.
Yeah.
And I ask them, do they have general symptoms like tiredness, fatigue? That's a very important question.
Yep.
Then I ask them, do they have any unusual lumps or bumps? Have they had any weight change? Have they lost weight? I ask them, do they have any unusual bleeding? And I ask them, do they have a fever or abnormal sweating? Because if you ask those general questions, you often find that if they've got a serious problem, it shows up with that. And so I make sure I ask them those very basic questions.
When you've got patients who are returning to see you, your regulars, but who you might not have seen for a little while, do you approach them in the same way, or have you got a slightly different approach?
A slightly different approach. I just ask them why they're here, of course, but I said, and I go through the notes quickly. I said, now, last time you were here, you had this particular problem. How have you got on? Have you had any problems in the meantime? I just try and find out whether we are dealing with an old problem or a new problem, and then just ask them why they are here, what is their main concern.
In general practice, a patient's often bouncing between a couple of doctors, particularly if you're part-time or you do clinics in another more remote location.
They do.
How do you deal with the interaction between doctors and with patients who are seeing multiple doctors in the same practice, or perhaps doctors in different practices?
Well, I think that if you've got good history, you should be able to tune in to what's been going on.
Yeah.
And I sort of just confront them gently. I say, you've been seeing other doctors, you've seen Dr. So-and-so, and what did the doctor say, and what was the consultation like, and were you happy with the outcomes? Just to get a sort of a background as to what they're here for. And quite often you find they're quite happy with the other doctors, and they're seeing you because
You've got an appointment
got an
available.
appointment when it's available.
John, how do you get the patients to tell you exactly why they've come? You know, some of them beat round the bush, or they'll come out with the real problem after 20 minutes or so. Do you have any tips for actually extracting it?
I ask them now, why are you here today?
Yep.
What is your particular problem? What is your main concern? So that I can try and get it up front. But sometimes you're quite right. You do get a sense that they are beating around the bush and there's something bothering them. I just stop and say, now look, I just get a feeling that there's something else that's bothering you that you haven't told me about. Would you if that's the case, would you like to talk about it?
Yeah.
And so it's a sort of a confrontation, a gentle confrontation. And quite often it is amazing what comes out. If, however, I sense that there is something and I'm not getting the answer, I then have a few questions I ask them.
Mm-hmm.
I just say, how are things at home?
Yep.
How are you getting on with your loved ones, with your spouse and your children? Do you have any problems, any relationship problems? And then I say, how are things at work? I said, are you getting on all right with the people you work with your bosses? Do you have any problems with being bullied? So I just ask a couple of questions like that, which often gives them an opportunity to give you an insight as to what's bothering them.
When a consultation hasn't gone well, or you get that sense that it just wasn't quite satisfactory and you didn't quite connect with the patient, how do you go through it and work out what went wrong?
Well, quite often, unfortunately, the way you think about it later,
Yeah.
after the event, and you think about it, and I find personally the main reason it doesn't go well is that you are busy and distracted, and you're not really tuning into the person well. It's probably you, the doctor's fault, rather than the patient. But the patient may also be distracted. That's why I think it's very important to have a process, what we call the consultation, the management interview, which is in my textbook under the management interview, that at some stage you evaluate the consultation.
Yeah.
You're saying, now look, I just got a feeling we haven't really done very well with this consultation. Would you like to tell me what you've got out of it, and if there's anything that you'd like to bring up? Perhaps you might like to just give me a little summary of what we've talked about.
Mm-hmm.
And that gives you an idea where we may have slipped up.
Okay, so that's great when you've actually got the patient
When
there.
you've got the patient.
What about when you're reflecting afterwards? Do you go through it with any kind of system?
Well, it's just something that bothers you.
Yeah.
I remember once when we were having some building structures done at my clinic, and I just had seen a patient in the surgery, and then I slipped around to where the new building was, and she was walking out past with her husband. She said, that didn't go very well today. I don't think the doctor was interested in the problem. And that was a real wake-up call for me.
Mm-hmm.
Because I realised I wasn't particularly interested in the problem, because she used to moan and groan about a whole lot of things.
Yeah.
So next time I saw her, I really paid a lot of attention to her.
Mm-hmm.
And so one thing you can do. The other thing you can do, and it used to be very easy for me in the country, more so than the city, just ring them.
Yep.
And you say, look, I'm just wondering how you got on. I just had an uneasy feeling that I might have missed something and that I was concerned about you.
Mm-hmm.
And I can tell you they are very impressed when that happens.
Yeah.
Occasionally I've had to do that, and I still do it.
Mm-hmm.
But it's probably the fact that your conscience gets at you sometimes, that you feel that you haven't given the patient a good outcome.
Yeah.
But it's usually a time issue. You are racing against the clock, and you sort of brush things off, which you shouldn't do, of course.
Yeah. So is that how you deal with patients who are angry or very dissatisfied?
Well, once again, it's a matter of confronting them, and if they say they're not happy, or if they're angry, you say, look, I'm sorry we've had that outcome. That's not the way I want it. I want you to be happy with me as a doctor. Is there any ways, do you have any advice for me how we can make that better?
Mm-hmm.
Sometimes you feel, of course, that it's not going to go far, and it's best just to not enter into any conversation with them.
Yeah.
But I think that the secret of getting on with patients and avoiding that is to listen to them. I have two things in particular, which is very important in consultation, to develop empathy. One is you listen, and two is you call them, you are nice to them, and you call them by their name that they'd like to be called by. Mm-hmm. They really like that. So at the front of my sheet in their notes, I have a little note to remind me, patient likes to be called by such and such.
Yeah.
patient doesn't like having injections. I've learnt that from other doctors. They put little memos in the front of their notes.
I've got a little one in Medical Director occasionally that says, hard of hearing, speak up and face the patient.
Well, that's good, and I think that we have to discipline ourselves to have a little system about that. And but I think if you are kind to them and you listen to them, and if they get upset, that you say, look, I understand why you're upset, and I don't want you to be like that. And sometimes just touching them just on the back of the hand or something like that, particularly if they're upset, often leads to a good relationship with them. So they can be very forgiving if you are kind to them.
And how do you deal with patients who complain to you about other doctors and the way they've been treated by other doctors?
I shut my mouth and bite my lip. I find one of the commonest causes of litigation is what doctors say about other doctors. So I just might say, I just either ignore it and just say, oh, I'm sorry, didn't get on too well with Dr. So-and-so, but I just leave it at that.
What about those patients who present you with the overwhelming list of complaints, particularly if they won't give you the list so that you can see what's important? How do you get them to sort out some priorities?
Well, that's always a problem. I say now, you've got a lot of complaints. We've got to work through this. First thing I want to know from you, are you depressed? Do you feel depressed? Do you cry much? Do you have trouble sleeping? So on. Because often that's behind it. There's a depression issue or some severe anxiety. But then I say to you, what is the most important thing to you today? What problem or what 2 or 3 problems are most significant? And work through that. And I say, look, you've got these other problems. You might want your ears washed out, but I want you to make an appointment to see me in a week and we'll deal with the other problems. That's the way I get around that. It's not an easy one though.
And do you have any particular tips or approaches that you would use differently for Indigenous patients?
Yes. I've had many Indigenous patients. I find, once again, they are human beings who like to be treated with a lot of respect. They like to be called by their proper name, the name they like to be called by. They like you to listen to them and give them a lot of respect. So you work hard at that. But there again, some of them are very private and they have their various businesses which you have to be aware of and respect. So you don't talk about things that you feel that they're uncomfortable with. So what I do is I enter into conversations with issues that they like, such as you might talk to them about the football, what football team they support, about fishing. So you start off with something like that and then you get their confidence. Sometimes the language is a bit of a problem, and you have to learn ways of repeating things and just getting them to so you understand them. You might say something, look, I don't quite get your point, but my understanding is what you are saying is that correct? So you just got to keep rechecking with them. And if there's someone outside who can give you a better understanding of what the problem is, you might call them in with their permission. That's what I also use with people who have a language problem. They may be from another country. You have to have a system of calling someone or getting someone in who can give you a better history.
How do you find working with something like the telephone interpreter service?
I found it quite good. If you can get them.
If you can get them.
Yes.
No, they're tremendous. Certainly in Western Australia, you can usually obtain somebody who speaks the language or book them.
I've heard that it is very good in Western Australia. One of the best interpreters I find are children. So
as long as they don't have an agenda themselves.
That's right. If you've got some children outside and the patient doesn't mind, you can get them in to interpret for you.
What happens when the patients ask you about something or develop something about which you know absolutely next to nothing?
Well, that happens. And what I tend to do is say, well, look, I don't know a lot about this. This is a fairly tricky one. But I will endeavour to look it up and get back to you. I have a lot of patient education material in my surgery, and I'll get it out in front of them, and if I haven't got it, I will say I will get it, because there's a lot of information out there on the internet too.
And the poor patients find it really hard to trawl through and find something that's not only pitched at their level, but also doesn't contain wildly inaccurate statements or claims for instant miracle cures.
Well, that's right. So once again, I'm a great believer in using the telephone. I'll ring them up maybe later that day or the next day or a week later with some information, or might post them some information and make an appointment to see them.
Yeah.
Or if I feel that there's someone, I can refer them to someone who knows a bit about that, I don't hesitate to refer them. Or even call someone in from the practice, which people often do with me.
Yeah.
And my colleagues, they'll call me and they say, "Hey John, we've got a problem here, we think you might be able to help us." And I think that's good.
Yeah.
And it works both ways. But I used to get embarrassed about it, but it doesn't bother me anymore. I think patients are quite happy if you don't know, that you tell them, and that you make some attempt to help them with the problem.
I think most of them think it's quite tremendous if you've got several doctors who can look at their skin lesion or their funny rash or their feverish child and give another opinion.
Yeah, I think interesting you say that. It's usually a skin rash.
Yeah.
That's the usual one.
John, when patients come in with a really simple problem or a very one-dimensional thing, like they've developed a post-viral cough and they're not sure whether they require antibiotics, how much of this consultation process do you go through and how do you abbreviate it?
Well, to be quite honest, when these patients come in, I think, oh, this is good. It's going to be a fairly brief consultation. It should be fairly simple, but you still got to be a little bit careful and ask yourself, this seems a trivial complaint. Is there something behind it?
Yeah.
I'm always very cautious. I could be missing pneumonia or even cancer. So, I just do a quick check. I will spend 1 or 2 minutes with a brief history and ask them what their particular concern is. So I always check with that. I don't let them off that easy, but I think usually it's often fairly trivial and easily explained. I also have a system of making sure they don't walk out feeling as though they haven't had a value for the consultation.
Yep.
I will offer them something simple like going and doing some inhalations or taking a particular cough mixture, just to make them feel okay about it, so they haven't come to see you and so that you feel it's been trivial.
I think many of them are very reassured if you do a quite thorough examination and have a proper listen to their chest and look in their ears and check their temperature.
Well, over my almost 50 years of experience, I find you can't reassure people unless you've done some form of physical examination, and particularly putting stethoscope on them, looking in their ears. It doesn't take long, but particularly so the older people love their blood pressure being taken. If they come in for a checkup and you don't take the blood pressure, you can tell the consultation they're not being happy with it. Yeah. So that's something I've always learned to do routinely. Do it quickly.
So yes, it's still going to be a 10-minute consult, but 10 rather than 15 or 20.
That's right. And if they've got a headache or a backache, you've got to do some form of examination. Just get the skill of doing it quickly and in such a way that if there is a problem, you pick it up.
John, those patients who present with really general symptoms, and the majority of them are, "Oh God, doctor, I'm so tired," usually happens after you've had a torrid night in the labour ward and you're more tired than they are. But how do you sift through and work out whether they've got something that's very significant?
Well, I really analyse the presenting symptom. What do they mean by tiredness or fatigue or weakness? What do they really mean by it? How does it affect them? I always take that important history to find out whether they're depressed. The commonest cause of this is psychological issues such as depression and anxiety and stress. So the questions revolve around that. What's going on in your life? What's it like at work? you're having financial problems, you're having relationship problems, and then there's those vital questions related to lifestyle which indicate depression. One is, how's your energy, which of course in this case is going to be down. How's your sex life? Are you interested in sex? Are you having any problems there? How's your appetite? And how are your bowels and bladder working? And how's your sleep? Those 6 questions. And often is a reflection whether they have a true psychological issue, such as depression or anxiety. And when you're asking those questions, things tend to come out. So the sleep is very important. Their work's important. These people might be being bullied.
Yeah.
They may be having a relationship problem. Their spouse may not be particularly interested in them. There may be a sexual issue, which you try and work out. But at the same time, I have this little model of what is the probability diagnosis, and it's going to be what we talked about,
Yep.
a psychological problem, just burning the candle at both ends is a common one.
Yeah.
What can't I afford to miss in this person, in this very tired person? And of course you can't afford to miss malignant disease or an endocrine problem. You could have Addison's disease or hypothyroidism. And you can't afford to miss an infection.
Yep.
They may have HIV, they may have glandular fever. So that's the way I approach it. What can't I afford to miss? And then I ask myself, what are the things I often miss in these people? And it may be something quite simple. So that's why you have to take a history, like I said, asking those key questions.
Yeah, I'm finding at the moment that the things that are more common in my patients that I don't always think about, sleep apnea.
Sleep apnea is one.
And patients who are having menorrhagia but don't realise that they are, because their periods have always been terrible. So you ask them how their periods are and they say, oh, they're just like normal. And then you find that normal means that they, change every hour for 7 days of every month.
So I have always have had on the wall behind my patients what I call the masquerades.
Yep.
The 7 masquerades. And the checklist is depression, diabetes, drugs. Drugs are big in this area of fatigue. They're often maybe on some drug they won't even want to talk about. So you go into that. Anemia, which you've referred to, with menorrhagia. There's endocrine problems. I've alluded to that, particularly thyroid.
Yeah.
So it's thyroid and other endocrine problems. And the other one is urinary tract infection. So they sit up there and I use it as a quick checklist if they've come in with fatigue.
Conveniently situated behind the patient's
Right
head.
behind the patient. And Max Camion was intrigued by this, and this triggered this whole business of the Murtagh model, which it's now taught quite widely in general practice circles.
Yeah.
It's just a sort of a handy checklist, and it applies particularly for the tired patient. Often it's a simple problem, which you can identify very quickly. Like my son-in-law, he's got 2 jobs.
Yep.
So he's tired. And why has he got 2 jobs? He's got financial problems, which tires people out themselves. So that people have a lot of worries in their life.
Yeah.
And
I think farmer equals tired, particularly female farmer equals tired.
Well, farmers have it really tough. And that's something worth keeping in mind about them.
Yeah. Finally, John, do you have any hot tips or little traps that might trip up unwary players?
Oh, well, I think the main thing, as I said before, is to have the antenna out and to be finding out the patient's agenda and think about what they're not telling you, and to try and have a little system to say, now look, I have a feeling there's something bothering you that you're not telling me about. Would you like to tell me about it? I think that's a very good tip, but also just to, if you have a good empathy with them and you're kind to them and interested in them, they are very forgiving.
And John, are there any particular resources or internet resources that you would use that you think are especially good for GPs?
I think there's a Better Health channel which has a lot of patient education.
Yeah.
I know we have it in Victoria, and I know other states have it. And the Patient UK is a sort of a resource system which has enormous number of patient education material. I think they're the good ones to go to rather than just Googling anything.
Mm-hmm.
But, and of course there's always some good textbooks. And I think the patient education material is really very useful to help you understand and pass on to patients.
It usually gives you a good general practice understanding and also somewhere for you to find something to look up.
Well, a lot of people call it doctor education.
Well, I would
Because
agree
you-
with that.
because
We're all
you-
patients at some
Because
stage.
you're learning as you do it. But I think patients are very impressed if you give them an education handout, and particularly if you invite them to come back and talk about it. You always got to keep the lines of communication open, rather than just say goodbye, that's it. Just say, look, if you have a problem, come back, call me, or come back and see me. I think that's very important.
John, thank you for being with us today.
Pleasure, Olga.
Well, that's all for this special edition of Rural Doctors. A big thank you to Professor John Murtagh for his time and expertise. And don't forget, if you'd like to review this programme or any previous programme, you can watch them online via the Rural Health West website at www.ruralhealthwest.com.au. And thanks to you for taking the time to join us. Good night.